In soft tissue. These slides are going to be slightly different from the ones that you have. They're very much the same, and it's not a written test, so y'all will be okay, all right? Don't complain to Major Sandoval that I use my slides that they kind of cannibalize. Fair enough? Or complain anyways. After that, if you want, we can push through and grab peripheral IV access using ultrasound guided, which is very similar to regular IV access, it's just you can see when you miss. And that will give us all class tomorrow to do practicing for the test, which I think would be more useful. Sound good? Yes. Awesome. I'm still Kagan Williams. I am a captain still in the United States Army. And we are going to be talking about musculoskeletal and soft tissue ultrasound. I'm not going to be as moving around the room as I usually am because my back is all jacked up and it hurts. So I apologize, but we'll get through it together. And this thing should still work, so sweet. All right, so you have a reason to do a musculoskeletal ultrasound or a skin and soft tissue ultrasound. There's a lot of really great things that you can do with this. You're going to want to use a high frequency linear probe. I said I wasn't going to move around, and I'm still walking, but that's okay. High frequency linear probe. But the challenge with that is the couple millimeters that are just after the footprint of the probe are actually kind of blurry. So you need to have a good standoff if you're going to be looking at things like fingers, or you can't really submerge someone's head in water, that's frowned upon. But fingers and toes, you can actually use a water bath to stand off to get that good view. You can also theoretically use a glove full of water. Every time I've tried that, it hasn't worked, but they say you can do it. You can also use FLARP, which is an excuse to have it. It's a noise putty, and it conducts sound waves really, really well. And it's non-toxic, and it's fun. We're going to post up like this. I'm not ignoring you guys this time. It's just this feels better. Okay, so anatomy. We kind of all know what that is. Yes, sir.
Can you hear all these lights right here, sir?
I can. Maybe. Good enough? We're going to fall asleep. It's after lunch. We talked about this. All right. Yeah, so at the top of the skin, you have the epidermis and the dermis, subcutaneous fascia, muscle, and then bone down at the bottom of the screen. Does everyone kind of see right there that hyperechoic white line that looked kind of like the vertebral bodies in the FAST exam? It's still bone. Okay, so obviously you have your eyes. You don't necessarily need to use the ultrasound, and you're going to use a skin exam, and you're going to look, and you're going to see that the left side of this person's body, the left leg, looks different than the right. So that could be cellulitis, it could be edema, it could be a lot of different things. And you're going to put an ultrasound on it, and you're going to see cobblestoning. Does everyone see that? Yeah. Understand what cobblestoning is? Like that old-timey street with the cobblestones and stuff? Right. That is fluid in the interstitial space, extracellular, creating those lobules of fat that look like cobblestones. That just means that there's edema there in the setting of the right clinical context. That could be cellulitis, or it could be edema from their heart failure. What you're really looking for is not to confirm that there's cellulitis there, because you can see that with your eyes. You're going to see if there's a fluid pocket that's worth jabbing a needle or a knife into that can actually express something that's not pulsing. Because if you express something that's pulsing, that's bad, right? Okay. And then obviously you see here the tibia down there, and then the anechoic nothingness after that, because the sound waves don't really communicate well with bone with these transducers. So here's another good picture of cobblestoning. It's right here. It's cobblestoning. The problem with the musculoskeletal skin and soft tissue exam is it's kind of just there, and we're not going to see any of that when you try it on each other. So we're going to go through the slides kind of quickly. Here's another, can you close that window right there? For you guys over here. Another picture of pretty obvious cobblestoning. Does anyone not see that? I can highlight it again. Or we can zoom in if that's better. Now, this is different, right? We see that over that red, inflamed, indurated, painful area, and they said that they got a mosquito bite or a splinter a couple weeks ago, and that it's really swollen and hurts, and it may be a little fluctuant if you push on it. That is an abscess. That's something that's worth jabbing a needle or a 11 blade into to try and express after local anesthetic. Don't just stab people for fun. But you can see inside there, this is a kind of complicated one. This is the purulent material that's kind of just sitting right there. If you were to put color on that, you would hopefully not see flashing blue or flashing red, because that would be a pulse, and that would be, again, something that we don't want to stab, right? This is what you would do if you wanted to do ultrasound-guided drainage of that abscess. You could stick a needle into there and then extract the purulent material and bill higher for it, right? Okay, you can also use ultrasound to detect foreign objects. Foreign objects can also be detected with a lot of other different ways, to include X-ray, but there are some foreign objects that you cannot use X-ray to visualize, like wood. But you can also use metal for ultrasound and, of course, X-ray. So this is what a needle looks like on, or a metal, in this case it's a needle, looks like in soft tissue. Does anyone not see the straight hyperechoic line with reverberations? It's okay if you don't, I can highlight it just in case. The benefit of this is you can also see right over there how deep it is on most of these screens, because you'll be able to see how many centimeters down, and that will determine whether you want to maybe go after a bedside or have to call surgery, because if it's like 3 or 4 centimeters deep, that might be a little too deep for me to want to go into it bedside. Make sense? So like, for example, this one over here is not communicating with the surface and is pretty deep. And it's called a needle because someone was nice and identified it for you. Glass, you can also see glass. Someone came, they were running and they punched a wall and then they skidded and fell on their bike or whatever. And you can see not necessarily the obvious glass, but the shadow. Does everyone see that highlighted anechoic or without echoes shadow right there?
Yes.
That is the artifact that's going to clue us into the fact that there's glass there based off of the story. Because you're not necessarily going to see the glass, because glass is glass. And you probably wouldn't see that on X-ray either, but you will see the absence of return due to the refraction of the sound waves. Make sense?
Yeah.
Sweet. Here's another glass. The shadow right here tells us that is glass. Also, it says it's glass on top of the screen, and some of us save these images for us. Okay? Now you have someone that was riding their bike and they skidded out on the asphalt, and a couple days later they said it still wasn't getting better. It's red, inflamed, and you see cellulitis, and you confirm cellulitis. You don't see an abscess, but you see something that looks kind of like that. That is gravel. That's something that you can see under ultrasound that would be worth getting out, because no amount of antibiotics you throw at this is going to make that gravel go away. And that gravel is going to be the itis for the infection, regardless of how much antibiotics you throw at it. Here's wood. You can see that this wood is probably about 2 centimeters deep here down at the bottom, which means that it's a splinter that's of pretty significant depth. Again, from personal experience, there's no amount of antibiotics that you can throw at that that's going to make that wood go away. This is another one that's wood. You can see the shadow deep to it. Does everyone see that linear line? It's kind of convenient that it's straight. And then with the measurements, calipers down to it, and then that shadow deep to it. That's what wood would look like on ultrasound. You would not see that piece of wood on X-ray, but you would see it on ultrasound. So if they said, hey, I was running and I ran up a wheelchair ramp that was made out of like plywood, and I think I got a splinter a couple days ago, and now pus is just pouring out the bottom of my foot, the X-ray is not going to help. Ortho will still want it, so get it, but the X-ray is not going to show them, the ultrasound will. Okay, you can also use it for tendon injury. We're going to talk about the Achilles tendon, but you can also use this for shoulder, elbow, knee, any sort of other tendons and ligaments that you want to. The Achilles is just the classic example, because that's how you're going to diagnose Achilles tendon rupture with imaging, as opposed to the Thompson's test, right? You're basically going to look for discontinuation of the fibers. There's a hematoma will be present. If there's a bony fragment from revulsion, things of that nature. What you'll see over here, that they don't really have it in those true classic planes of like sagittal and transverse. They kind of have a little cattywampus. That's because of the curvature of the, cattywampus is a real word. It's because of the curvature of the Achilles tendon. You want to make sure you have good contact. That's another reason why FLARC would be beneficial, because it maintains its shape, and you can use that to eliminate any air between the probe and the skin, right? So you put it on there, and you can see that this is the left, because it is nice and marked on the left-hand side. And we see, apologies, close up over here now. So you can see over here that we have this striations, what's kind of like if you took coax cable and cut it alongside, that's the Achilles tendon. You're going to go from the insertion to the origin, and you're going to trace that if you're concerned that there might be a rupture of some kind. Okay, that's what a tendon looks like. Here is it in video, and you're going to see a funny word called anisotropy. What that is all of those parallel lines that make up the tendon can have, what's it called? They'll mess with the sound waves, and not all of them will make it their way back to the probe. So what ends up happening is it will look like there is a break in continuity. The benefit of having the ultrasound probe in your hand is you can fan through the structure, and if the break is only there in certain views but not in others, and is continuous in other views of the same area, that's likely an artifact called anisotropy and not a tendon rupture. Does that make sense?
Yes, sir.
Okay, you can use a video, move it around, make sure that you see what you're looking for in multiple views. It's hard to pause these, but if you look right around here, see how it gets kind of schmutzy?
Yeah.
That's what the anisotropy is doing. It's giving the artifact kind of like dirty shadow. Compare that to an Achilles tendon rupture. On the left-hand side, you have the long axis, and on the right-hand side, highlighted here, is the short axis of we have tendon, then we have messed up tendon, and then we have absence of tendon. Right? You probably don't need an ultrasound to diagnose that severe of an Achilles tendon rupture, but it's cool to see, and people will upload it to the Focus Atlas. Does that make sense?
Yes.
Yes. Cool. This would be a strain or just inflammation of the tendon. You can see that it is thicker than it should be because it goes from here and it should kind of continue on in roughly the same size after it reaches its full size after leaving the calcaneus, which is what this is. And that belly is way too big. So there's clearly some trauma that happened there. Something that would be worth looking into further. How about these? You see those weird little ossifications? Think that's emergent? Do we think we need to evacuate that person? Correct. Leading questions, the answer is no. That's just old tendon injuries. They probably hurt their Achilles tendon at some point in their past when they had no frontal lobe and thought they were invincible, and now their ankle hurts because they were stupid as a younger child. Nothing to do for that other than Motrin and tell them good luck with the VA. So, partial tendon ruptures, you will see a change in width, a partial disruption like that right there that you can measure, a focal hemorrhage, and then there would be no retraction with movement of that tendon because it's still kind of sort of working. Does that make sense?
Yes.
And there's an arrow for positive arrow sign in case you missed it. Okay, you can see an effusion in joints, so you usually visualize on ultrasound. It's anechoic or mixed echogenicity, which means that it's either fluid or fluid with a little bit of schmutz in it, potentially blood. There's no color flow, that's good, that means it's pulsing, and that's bad. Well, it's good to be that, but you don't want to be jabbing needles into pulsing things, that's bad. And then you want to get two views like everything to make sure that you have a good idea of how big that three-dimensional shape is, okay? You want to compress with your probe because that will show you that it is fluid and not just some weird artifact, right? So you have a couple different ways to do this. I'm going to show you the most classic of the different ways to evaluate for effusion of the knee. You want them in the supine position with slight flexion. You can support that knee joint with a towel, and then you're going to put your ultrasound probe in the prepatellar space, looking at the prepatellar bursa, in the sagittal and transverse. And you're going to go to the lateral and medial, and then you can continue on to the infrapatellar. I don't care about that one as much. And you're going to look for things that are going to be anechoic like that. That is a fluid collection that you could potentially use a needle to draw out and make their knee feel better, right? Because it's the pressure of the fluid that is causing their discomfort. The reason the fluid's there is because there's some sort of trauma to it, but we can make them feel better by jabbing, causing more trauma and jabbing a needle into the joint space. Here's one that is subpatellar. If you look right there, I'm going to clear that away, but you can kind of see just deep to the patella, there is a collection of fluid. It's better on my laptop than on these projectors, but it's there. Okay, you can also go to the elbow and look at the electron fossa and the coronoid fossa. You're going to use the same thing where you're going to go sagittal and transverse up there, and you're going to see a nice effusion by the bone, the capitulum. And of course, in real life, they're not going to have all these nice labels. I apologize. So you just have to know your anatomy. But you will see an elbow fusion at the radial head if you know where you are. Okay, you can also use ultrasound to identify fractures. It's actually much more sensitive and specific for fractures than X-ray for the ribs. And we're not going to have CT scans on our backs, so we can't necessarily use them as much as we would like. They appear as you would understand, a discontinuity of the highly reflective bone tissue. And they should be at the point of tenderness. So you can hand your probe to the patient and be like, don't drop this. Put this where it hurts the most. And then you can look there and you will see probably a break in the bone, and that would be a fracture. And they're like, wait, a fracture means it's broken? And you say, yes. And then sometimes there'll be positive arrow sign, like you can see right there. We'll zoom in for you. Does everyone see that break in the bone? Does everyone see the arrow? Who did it? Here you can see at the physis, and then you can see at the fifth metatarsal that there's a fracture right there. Not at the physis, so it's not interarticular, and it's not involving the growth plate, but it is on the shaft. And then you can also use it, unsurprisingly, for a sternum, because it is very superficial, and you can see that that person has a sternum fracture, and that's probably suboptimal. Here is another fracture, a discontinuity in the bone that is pretty close to a joint space, so that would be potentially concerning. There's another one right there. Again, they're going to say, hey, it hurts a lot here, and the story is going to tell you that it's a fracture, right? This one's a wrist with a pretty decent amount of, actually I got to take off the zoom, a pretty decent amount of shortening, and there are ortho words. Do we have an ortho person here? It's a broken fracture with some shortening of the long bone because of that. You have a little bit of a fracture right there on the wrist. Okay, so you want to use a linear transducer. You want to scan in two planes. Long axis view and short axis view of the point that you're looking at if you can't get it at the body. You want to point the probe marker again toward the patient's right and their head because we're dealing with body medicine and not heart medicine. And if you need to use a standoff for the fingers and the hand or the toes, you can use a water bath or floor. Questions on that? Too fast, too slow, just right? Nice. All right, one more one, right? You want to stand up or are we good? Sweet. So, the slides that I got these from used to have a different name, but I had to change them because I can't get away with the name that was, but it involves the tip of the needle. So, sorry, you can get a little bit of a laugh still. So we're going to do ultrasound guided peripheral IV placement. This is always interesting to teach people that know how to do IVs before because you guys are going to have different habits than the people that have never done an IV before. You're going to have some things that are going to be much easier for you than the people that have never done it, and then some things are going to be a little more challenging, like trusting the ultrasound in your eyes as opposed to the flash chamber. Sorry, this is one thing that we use at different conferences, so I have to have that disclaimer. So we're going to talk about how to get ultrasound-guided IV access. We're going to review key sonographic principles, and then we're going to discuss tips and tricks to optimize the first pass success. The nice thing about this is peripheral IVs and self-delivery technique central venous access are about the same, just a little bit different. So the steps for success are important. You want to pre-scan and find what you're looking for. You want to make sure that you are optimized for positioning so that you give yourself the best chance of success and you're not looking one way and trying to stab a different way. You want to make sure that your equipment is prepared before you puncture the skin, because otherwise you're going to be kind of stuck if you have good cannulation into the vessel and then you haven't actually prepped your IV. That will be problematic, right? And then you want to make sure that you are in the right place, and then you want to place the dressing. So pre-scan. You're going to want to use a linear probe. It's high frequency. You want to put the indicator to the left. This is different from everything else that we've done because this is a procedure, right? And then you want to have the right settings, vascular, venous, or arterial. Usually the one of those three, if not more, are an option on the machine. Go for whichever one is the most appropriate. Procedure mode is a reasonable thing to do. Sometimes you can actually angle the sound waves to come off the machine to highlight the needle, which is beneficial. So you want to put center line mode. If you want to have the center line on the screen, don't use the M mode cursor because that will cause, especially on these older machines, spooling in the back behind the scenes area and actually decrease frame rate, which will affect your accuracy. And then resolution versus penetration modes. Again, San Antonio body armor people, you might need to use penetration. Most of your skinny, healthy, or fit individuals, you can probably use resolution to optimize the clarity. You're going to want to have a good grip. These are examples of the bad grip. You can see here that the person is touching the tail of the probe and not resting on the patient, and they're going to withdraw because that needle is sharp and it hurts. You're going to see that they are in a bad, not 90-degree angle, which we'll get into a little bit later, and that they don't have good, like I said earlier, capture, okay? The better grip you have over here, you can see a nice 90-degree angle of the needle and the probe. They are resting on the patient, so when the patient moves, they move with them, and they're not going to slide around because they're anchored to the patient in space, right? Anatomy, it's all a little bit different, but it's also kind of the same. So you want to put on the tourniquet, you want to look for anatomic variants. You can ask them, hey, where do people usually get success when they cannulate you? You can use regular words, you don't have to use the fancy pants words. And then laterality, prefer left versus right, and then just make sure the patient's set up for comfort, you're set up for comfort, and the machine is set up for you. You're going to identify a vein and a vessel by compressing, similar to the DVT scan, and you will see that the artery pulses and the vein completely collapses. Does that make sense? Right, so we're going to go for venous access, and that's not different from getting an arterial line, right? Okay, so you want your ideal vessel to be straight. You want it to be as superficial as you can. You want it to be collapsible. You want to be as far away from arteries and nerve as reasonably possible. And then you can use Doppler to make sure that it is a vessel and not just, something else. So positioning, this is for you and the patient and the machine. This is two people. One of them is lying down. He's the patient clearly, and Cam is squatting down, trying to do IV one place and looking. Obviously, you can see the edit error here. But he's looking roughly 9 degrees from where he's going to be moving his hands and moving the needle, right? That's not going to help your brain. The amount of mental gymnastics that you're going to have to do to figure out the area that the directionality that you want to go is not ideal, right? So you can see that that is different than that. This is better. Plus, he's got the loose steel look, but he's standing up, he's looking at the machine, and he's going to be driving the needle forward towards that. Does everyone understand why this would be better than the previous one? Yes. This is also why you can see we have the indicator towards the left, because if it's towards our left, we can also have the indicator of the machine towards the left, so we don't have to flip things in our eyes to want to go left, but we actually point the arrow right. Does that make sense? Yes. Prepare the equipment. This is how you're going to set up. This is the stuff that everyone who's done a lot of IVs comes second nature. You want your PIV kit, you want your flush, you want your gloves, you want your sterile probe cover, barrier, or tegaderm. If you are doing that, I recommend that you have at least a glove or a regular barrier or a tegaderm, because that will help prevent the transmission of many viruses. Tegaderm, the Hep C and HIV will still cross through that. Just something to be aware of. Sterile probe covers would be for central venous access, because if we're going to a deep central vein, we don't really want to bring in as much bacteria that we could potentially do, right? Because sterility protects the patient, the barrier protects the equipment and us, right? And this is what you can have, a way to have it all set up and done very nicely and nursing approved. You want to prepare the ultrasound. You want to make sure that you put a nice ultrasound gel, a copious amount of ultrasound gel without bubbles on the footprint, not like this where there's not enough, before you put any tegaderm or probe cover on. On the left here is a tegaderm, on the right here is a probe cover. They're kind of like gloves that you get on the wall. If you have these, great. If you don't, it's not the end of the world. It will be okay. The patient probably needs the IV more than you need to try and find the probe cover if you don't have that. Okay? Remember, hospital medicine versus Role 1 medicine, slightly different. Okay? And you can see here that the machine has a nice, even, almost fairly parallel artifact that shows that the sound waves are doing what they're supposed to be doing with the ultrasound gel, right? Okay, if you were to put on a sterile probe cover, you would have your sterility done. You would put on your sterile rubber bands, and you would grab your probe cover like that, and put more goopy gel that's inside the kit into the probe cover. And then before you went sterile, you would have we'll go with hung, the ultrasound over one of the IV poles if you have it, because then you can do this by yourself and not use somebody else to help you. And then you're going to grab it and then extend the sterile cover down as far as you can, and then put those rubber bands that you pre-charged onto your wrist on there, and you'll be good to go. and smooth out the gel. Okay? You want to have a longer catheter than your normal peripheral IV catheter, and we'll tell you why here in a second, but you want to have at least 2 inches in catheter length. And then you're going to prepare your equipment with the needle. You want to make sure that there's no burrs and spurs and rust and dust and all that stuff, things move freely, all of those things that you already learned. You don't have to worry about where the flash chamber is because you don't need to look at it, right? And you're going to puncture the skin. So there's a few different ways to do this. My recommendation is the non-continuous leapfrog method right here, but we're going to talk about a couple different ones. So the in-plane approach, the long axis approach, you're going to have your probe further down. There we go. Right there. Parallel to the vessel, which is great for nerve blocks and great for people that are really facile with driving needles and probes, right? Because then you're going to be able to do that, and you'll see it, and it'll be glorious, and you'll cannulate first time go, and no issue, right? Or there's some challenges with that, right? Because if we rotate this, you'll see that you have a small, less than 1 millimeter thick slice of the vessel that you can see that could be at a bias, either direction. And then the needle could also be at a different bias. So finding 2 needles in a haystack will be much more difficult than the out of plane or short axis approach, where you're going to see that as you run the length of the vessel, you will be able to puncture the skin of the needle, find the needle with your ultrasound while it's in the skin, make the needle disappear, advance the needle till you see the tip, advance the probe till you don't see the tip, advance until you see the tip inside the vessel. Do you see the tip, the needle tip at the top of the screen? It's that tiny little white thing. I'll see if I can highlight it. Right there, and it's about to cannulate on this one, right? See it?
Yes.
You don't have to be as quick as that, but you want to go until you see that tip, and then you slide until you don't see the tip. That's how you know you're not just following the shaft the entire way down. You can see how these jokes could go. Right? So once you're in the vessel, don't look down, don't advance the catheter, keep your hard needle in its place, drop the angle of the needle and the probe, maintaining this 90-degree right angle right there, and you continue to leapfrog until you have hubbed your needle into the vessel, because you don't need to remove the needle because you can see that you're inside the lumen of the vessel, right? So you're not slicing away willy-nilly inside the arm, you're inside the vessel. So you can actually make sure that the majority of that catheter is inside the vessel, right? Boom. And this is what it would look like. You see the dot in the middle of the vessel? You just keep running that until you run out of tissue. Here is an example of how to do the leapfrog on a blue Phantom. See the needle tip? See how they're moving until you get access, and then you drop it in here. All right, so some pitfalls. You are not 90 degrees to start, and then as you extend and enter further, you get less and less and less until you don't see the needle anyway, right? Here, you start off at 90 degrees, but then you rock as opposed to slide. And so you start off at 90 degrees, getting good insonation and more of the needle you see on the screen. But as you get closer and closer to your target, that angle becomes more and more acute, which means that less and less of the sound waves are coming back to the probe, which means that you see less and less. So angle of insonation is important. Don't worry, there won't be a test on that. Right? 90 degrees is better, and that's why you can see things like this right here. If you go to 60 degrees, you'll see things like that. It's a little darker, a little less easy to see. Now remember, this is in a water bath, so there's nothing in there besides the needle. Inside someone's soft tissue, there's a lot of fat and muscle and bone and other vessels and nerves and things, so it's not as easy to see. And then at 45 degrees, even less. And then, of course, as you can imagine, at 30 degrees, it's even less, right? So 90 degrees is what we're going to be aiming for. 90 degrees of the needle, right? Here's the same thing where you start off at 90, but, oh no, this is pitfall 2. Pitfall 2 is where you start off at the tip, but then you get to the shaft, and then you never quite stay at the tip, right? Here, you never actually not see the tip of the needle. You just see the shaft. This is how you go through that vessel that you can visualize. Make sense?
Yeah.
Right? So you're like, how am I missing? Why am I so far deeper than the vessel? Because you didn't actually not see the tip. So this is what it looks like. Right? Looks great. Looks awesome. Oh, shoot. We went through. Almost said an inappropriate word. Okay, so a way to mitigate that, if you care, is you can adjust the tip. And the way that you do that is you find 90 degrees from the shaft, which is what we're doing here. But the bias of the needle is actually at a 15 degrees. So if you go 105 degrees from the shaft, you can actually get 90 degrees from the needle tip and see more better, right? This is aim small, miss small kind of stuff, not that big of a deal. All right, so intonation of the tip and the needle tip is how it pops into view much more better there. See it? Neat. Okay. If you lost, don't jiggle. Don't just cut into their skin for no reason. You just slide back until you see it. And if you ever don't see it, just slide up to where you see the needle entering the skin with your eyes, put the probe in there, and then follow it down. You'll see how there's no reason for you to miss. You'll still miss. I still miss when I do ultrasound IVs, and it's frustrating because you're like, there's no reason for me to. Right? Okay. So this is, we kind of got ahead there. You start where it enters the skin, and then you run down. Sorry, it's a lot cooler when you build the slides out and it works well. But there you go. You can run it down, sharp, see that, and then now we're back and we're good. And then we get that 90 degrees, 105 degrees. Okay. So this is going to be a trigger warning for math, and especially trigonometry. SOHCAHTOA is a thing. Don't worry about it. Just know that someone did the math for you, and there's a reason why we go at 45 degrees, okay? So you can see here, this is a nice straight vessel that's kind of far away from the artery, and it's about like 2 centimeters deep, right? 2 centimeters from the skin to there. So if we go 2 centimeters back at a 45 degree angle, SOHCAHTOA says that we will hit the vessel with roughly 2.8 centimeters. And if we look at the 2-inch needle that we want to use, 2.8 centimeters means that half of the catheter will be in the vessel, so it's not going to get dislodged, right? But if you do 30 degrees as opposed to 45 degrees, math is kind of frustrating that way, and you don't quite reach it, so 4 centimeters. So again, with the longer needle, you'll still be able to make it, but with that smaller catheter, you would not necessarily make it, right? So longer needle, set yourself up for success, and 45 degrees, not 30 degrees, okay? All right, insert most of the shaft into the vessel. You can go back here, hang on. And we see this one right here, we got it in, but that's the one that's gonna get dislodged. You're like, oh, blue, they have weak veins. No, you just did a bad job. Here is okay because we have some of the vessel, some of the catheter in the vessel, but more, if we went at that deeper angle, we could get more of it in the vessel. This one's not going anywhere, right? Cool. Keep your eye on the screen. Don't look for the flash. You don't need to know if the flash is there. You can actually see your needle tip. Practice this. This is where the people that are really good at IVs without ultrasound say that they don't like using ultrasound-guided IVs because they know what they're doing. And you're like, yeah, but you can actually watch yourself miss or not. Do it this way. Now, take a pause. The easy part is done. Now you have to do all the stuff that the people that are facile with IVs are good at, which is lift the probe from the patient, advance the catheter, pull back the needle, apply proximal pressure, not on the catheter, remove the needle, release the tourniquet, right? A way to do that is if you think of this as the probe and this is my needle hand, I'm going to walk up to the front so you guys can see me. This is the probe and this is the needle. What you can do is rest. Once you have it in there, you can just lay the probe down on the patient. They'll be all right. It's not that heavy. And then keep your hand not moving where you have it placed. Grab the hub. Push your pinky or your ring finger down at the edge of the catheter to make sure that you're occluding the vessel. Take out the needle. You have your free hand. It's not going anywhere. It's not bleeding. And then you can hook everything up, right? Easy peasy. It's easy to say anyway. So now you can prove that you were in where you saw yourself go in by turning it to that long axis or tracking the catheter or needle, or in this case a Seldinger wire, which is for central venous access, and run it into and watch it into the vessel, right? place the dressing, and secure the line. So in summary, pre-scan, position, prepare, make sure you keep that 9 degrees angle of inclination or as close as possible, visualize the tip and then lose visualization of the tip and then find it again, move the probe, not the needle if you're lost, get as much of the catheter in the vein as possible, and then remember math is a thing. Good? Sweet, we just got through 2. All right, we can break up into groups and do some practicing. Yay!